Okay, well, good morning, everybody, and welcome to the Northern Lincolnshire and Goole NHS Foundation Trust Annual Members Meeting. My name's Sean Lyons, and I'm the Group Chair, which means I chair both Hull University Teaching Hospitals and Northern Lincolnshire and Goole Foundation Trust. But today's focus is around the performance of NLaG, and it's our pleasure to be able to present a review of the events of the last year, really, and to be able to allow members of the public to ask questions through the virtues of the technology we're using today, which is Microsoft Teams Live. So can I just make a few sort of housekeeping comments just to try and give people an insight into how this is going to work. So first of all, this session is going to be recorded and published on the Trust website. So for anybody that cannot attend today, then there's always chance for them to review this the events of today in their own time. And you'll be hearing from a number of speakers today on a number of very important topics. You can see here the annual report and accounts, overview of the year, importantly the annual audit report, and a couple of very important updates on the developments of the NLaG and Huth group model and where we are with the Humber Acute Services consultation. So the way this is going to work is that anybody that would like to lodge a question, and we're sorry that the technology only limits us to 10 people who actually can be on screen. So anybody that's hooked in remotely can still participate by using the Q&A facility within the screen. And if you do that, please feel free to ask your questions. We'll be fielding them as we receive them, but we'll actually try and answer them at the end of each session. So I'll ask for questions to be read out and try and direct them to the appropriate responder. And when people are doing that, could you please identify yourself so that if we are not able to answer the question today, then we will be able to get back to you directly. And all questions will be registered and published with the answers on the Trust website following this meeting. So hopefully that will be relatively straightforward. So we look forward to participation from members of the public, governors, and whoever else wants to be participating in today's events. So I think that's the housekeeping concluded. Hopefully that's clear. Can I just take any apologies, Alison, before I just move on to a few introductory words?
Absolutely. So we've had apologies from Paula Ashcroft and Shibnand, who have got work commitments. And we've had apologies from Karen Green and Mike Bateson due to medical issues, and Corinne Mannerley for annual leave. They're all of our governors. We've also had apologies from Wendy Booth in terms of annual leave, and I'll be representing her if needed.
Fine. Okay. Thank you, Alison. So very briefly then, colleagues, this meeting is taking place rather later than would normally be the case. So the last time this meeting took place was in September 2022, and for reasons of us being able to appoint auditors, and for them to do their work, we've had to slip this meeting, but everything is in place now, and hopefully you'll receive very good accounts of where our performance has been and where our finances are, and the audit will obviously outline that. But I just wanted to say that over this last period, since September 22 to where we are now, which is the 1st of February 2024, a lot has happened, and the Trust has made very significant strides in its quality and operational performance, although there's plenty to do in both of those areas. But it's really good to be able to use this opportunity to let people know that our position with our quality regulator in particular is much improved, and that was evidenced by us exiting terrible badge of special measures during the course of last year. And for people to be really aware that this is just a monumental achievement, and the effort that has gone in from staff to get to that position has just been incredible. And I'm really grateful to everybody that's made that happen. It's not an easy thing to persuade people that we're good to go on our own, as it were, but now that's been the case, and I'm really pleased that for staff that's put that effort in. I just want to say thank you to everybody that has actually made that happen. So well done to that for that. Lots of capital investment has been going in as well. Our facilities, particularly at the front end of both Scunthorpe and Grimsby, has been heavily invested in, and now we're able to operate most of these new developments live as it is now. And I'm hopeful that those who would rather not see people pitching up at the hospital at all, but when they do, the facilities they'll see, the emergency care areas, are much better than they've ever been, and really at a standard that is as good as anywhere in the country and better than most. So we have invested heavily, and we're now hopefully patients will feel much more comforted by the fact we've got better standards in there. The other thing just to mention is, of course, is that in November 2022, after many years of NLaG and Hooth collaborating on a relatively shallow level, if that's the right phrase, we announced that we were going to try and do something really monumental in creating a group structure that through the appointment of a single executive structure, we would bind these two organisations together operationally to try and make sure that we got the best of both worlds from the quality perspective, and that we were able, by joining those two trusts together, to offer much more attractive career development opportunities, and therefore hopefully attract and retain more staff than we have been in the past. So we created that or announced that in November 2022. And we're at the final throes of finalising the executive team and the organisational structure that goes underneath that. And I'm delighted to be able to introduce you all to Jonathan Lofthouse, who's the Group Chief Executive, and the executive team, most of which are online today. So we're really optimistic and excited about this. To combine these two organisations, are an entity that is the 12th largest in the country. It's got a £1.3 billion turnover, 17,000 staff, and we've got huge opportunities to leverage the great qualities of both organisations for the benefit of the public that we serve, and that's really the point. So we're very excited about what we can achieve collectively. Nothing's ever very straightforward about these things, but so far I'm really happy that we're making very good progress in getting good people in great jobs, and I'm very optimistic for the future. So that's about all I want to say, actually. At the end of this meeting, we're able to publish formally the annual report, so that will be lodged on the website, and hopefully members of the public and staff will find that of great interest. It's a lovely publication and lots of great information in there. So without any further ado, can I just ask whether we have any declarations of interest to cover here? Not seeing anything around that. So in that case, the next item is to receive the approved minutes of the previous meeting we had, which was in 22nd of September 2022. So these are this meeting to receive those. Those minutes were approved in January 2023. And I'm not aware of any urgent matters arising unless anybody either online on the screen or online through the Q&A wants to raise any. Right, so if that's the case, then let me just move us into the overview of the year. And this is Jonathan Lofthouse, Group Chief Executive, and Lee Bond, our Group Chief Financial Officer, to take us through the operational and financial highlights of last year. There are some questions that have already been lodged that ought to be answered within the presentations that are coming forward in this section. So I'll just ask that those are read out and covered, if that's okay, between Jonathan and Lee. So I'll hand over to Jonathan first, and look forward to hearing what you've got to say. So thanks, and over to you.
Chairman, thank you very much indeed. Ladies and gentlemen, very good morning. I'm Jonathan Lofthouse. I'm the Group's Chief Executive Officer. And as the Chairman said, I'm the Accountable Officer both Northern Lincolnshire Gould NHS Foundation Trust and for Hull University Teaching Hospitals NHS Trust. Sat in my office just over my shoulder is Dr. Kate Wood, who's the Group's Chief Medical Officer, who's available if we get any specific questions. But for the next 10 minutes or so, I'm going to speak to you with regard to some of the highlights over the 22-23 operating year. Now, I'm a little bit doing this as an imposter. So during the 22-23 operating year, the organisation was led by my colleague, Dr. Peter Redding. Dr. Peter Redding has now left the organisation, so I'm going to be reflecting the achievements both on his and his team's behalf for the 22-23 operating year. I joined the organisation on the 7th of August 2023. So the slide that is being shown in front of you reflects the activity and pressures that the south sites of the Humber, our Gould Hospital, our community services across the northeast of Lincolnshire, our Scunthorpe Hospital and our Grimsby Hospital have experienced as a collective. So the figures that are being presented are collective totality figures. And as you can see on the very top line, over the last 3 successive years, we've continued to see an increase in undifferentiated emergency demand coming into our emergency departments, both at Grimsby and Scunthorpe hospitals, which in turn has continued to see a rise in patients admitted to hospital, both as emergencies and for elective operative care and medical treatment, both at Grimsby, Scunthorpe and Gould. Similarly, as you'd expect, our discharge profile has equally increased. Clearly, if we're seeing more patients coming into the organisation, we must be processing, caring for more patients and passing them through our system. And as you can see there on the slide, we've seen an increase in discharge, and continuing out of the COVID pandemic of 2022, we continue to see large volumes of outpatient referrals coming through the organisation as we recover the elective and outpatient backlogs experienced by many hospitals across the UK. Our birth rate, both within the maternity services on the Grimsby site, the maternity services at Scunthorpe, and our community midwifery services, have dropped just slightly to 3,719 over the 22-23 operating year. And actually, that slight downturn in births is a phenomenon that's been seen UK-wide. So there has been a slowing down of birth and midwifery activity across England over the last few years. So there's nothing necessarily alarmist by that. It's just a general trend in population demographic. Moving slightly further down the slide, you can see that towards the bottom of the slide, we've seen a really sizable and significant increase in the number of operations, both elective and emergency, that we're undertaking across the south bank of the Humber. Again, this reflects our clawback in line with many other hospitals following the COVID pandemic and bringing stabilisation to patients who are referred by GPs, referred by other institutions and other medical professionals requiring operative care. I'll take the next slide, Sam. Thank you. Moving forward to reflect some of the significant events that have positively affected the organisation over the last 18 to 20 months. As the chairman mentioned at the top of our opening, we have made significant moves in our harmonisation relationship, both with the hospital and with the services provided by Hull University Teaching Hospitals. And I'll be speaking about that in a little bit more detail in about 20 minutes or so. But it's absolutely our direction of travel to create stronger, more harmonised clinical services for all of the patients across both the north and the south bank of the Humber, and bring the organisations and its workforce to a tighter knit together, and really, as the chairman referenced earlier, release the potential of our 17,000 staff and our collective £1.34 billion operating budget. But concentrating specifically on some of the highlights on the South Bank over the last 18 to 20 months, the most significant of which that can't go unnoticed is the move of Northern Lincolnshire Goole NHS Foundation Trust out of the formal National Recovery Support Programme, which is commonly referred to as Special Measures for Quality and Finance, and into a standardised requires improvement format by the Care Quality Commission. And this was really the culmination of significant and sustained efforts, both to bring about stabilisation of our spend, finance and investments, of which Lee Bond, our Chief Finance Officer, will speak about in a short while, but also systemically improve the quality of clinical services throughout and across all of our hospital sites and our community setting. And it's really important to echo the fact that the quality of care considered by the Care Quality Commission was rated extensively good across our organisations. Next slide, please. We've made really significant improvements to both our hospital sites and the environment within which our patients are seen and treated. And these investments have been tens upon tens of millions of pounds worth of investment. Today I'm broadcasting to you live from our Grimsby, Diana Princess of Wales site, and I'm just sat above our brand new emergency department and our new same-day emergency care unit that opened only 10 days ago. Investment of well over £20 million. We have very similar standards of investment that have been introduced to our Scunthorpe Hospital site, with again a brand new emergency department and further assessment capacity going live in a couple of months' time in terms of developing same-day emergency care within Scunthorpe. We've also been successful in undertaking a number of ward refurbishment programmes on our Scunthorpe site, and I'm specifically highlight Ward 25, which has improved both the patient environment, the care environment, but also enhanced our infection prevention and control measures within our core hospital sites. And further, and a little later on in this morning's conversation, Ivan McConnell, our Group's Director of Strategy and Partnerships, will be highlighting the progress and achievements that have been made in public consultation, considering the development of acute services as part of the Humber Acute Services Review and the public consultation that has been administered by our Integrated Care Board. Next slide, please. In terms of our performance headlines, it's true to say that our response to emergency and undifferentiated patients, which carries a national accessibility standard of 95% of patients being seen within 4 hours, has been a challenge not only for us but other hospitals around England. And whilst our performance in terms of hours and accessibility of patients has been below the national standard in 22-23 at 59.8% collectively, I can report that that performance has increased over more recent months. And as I've spoken about previously, the quality of the care environment, both in the emergency departments and with the introduction of same-day emergency care, is now significantly enhancing the experience of patients accessing emergency care, either at Scunthorpe or at Grimsby. As many members of the public will appreciate from national news media, ambulance services bringing patients to our hospital sites have experienced a deterioration in the speed in which patients are transferred from ambulance to hospital practitioner. And unfortunately, that is similarly the case across our hospitals on the South Bank. Again, these figures represent the 22-23 position, so quite a number of months ago. And over more recent months, the last 6 months, as an example, the organisation has seen significant improvements in the speed and quality of handover from patients between the ambulance service and our acute hospital units. We do, however, need to do far more work, both in the hospital and with partners, to improve the flow through our organisations. And in so doing, improve the speed and timeliness of emergency care, the speed and timeliness of care within the emergency department before being admitted to a specialist ward or discharged to a place of safety outside the organisation. The hospitals have really supported the wider health system across the Humber and North Yorkshire in terms of cancer and elective operating, and the provisions of mutual aid, which is where patients from other hospitals around the region come to hospitals on the South Bank for their care episode. This work continues and will continue into the next financial year, 24-25. We've also made significant improvements in the quality of maternity services, where we have, for a period of months, received additional support for improvement from national partners. And overall, our performance around infection prevention and control, both within our hospital sites and within our community service, has markedly improved. These are all very positive improvements for our patients and the population that we serve. Simon, next slide, please. In terms of staff, our greatest asset, the workforce that we employ and embrace to care for our population. We've been really successful over the period in moving forward with new and innovative recruitment campaigns, both within the UK and overseas, to both increase and bring in new skills and staff to the organisation. We've, over the period, increased new starters by 1,900 staff members, of which round about 100 are registered nurses and 25 doctors from previous years. We've also been really successful in developing international recruitment campaigns, both with the Indian subcontinent and the African subcontinent. This is allowing us, with our nursing professional colleagues, with our medical colleagues and our human resources team, to develop new career pathways for individuals joining the organisation. Those individuals continue to be supported not only by training and development, but by leadership strategies, one of which is our medical leaders strategy that has had really significant praise over the last 18 months. And in terms of being a good employer and continuing to value our staff, our human resources and wellbeing team have made a number of enhancements to staff wellbeing and staff health services to ensure that our employees are happy, healthy, well looked after, well supported and well trained whilst they're working for our institutions. Next slide, please. So as we move forward and reflecting on the journey that we've been on, we continue to prioritise the recruitment and retention of our workforce. We continue to seek supportive and developmental ways to nurture good, strong, caring cultures across our hospitals and our community service. Having established through physical rebuild new emergency care departments, both at Scunthorpe and Grimsby, and developed new same-day emergency care. As we move forward, we really want to exploit the benefit of those care environments, allow the clinical teams in those environments to provide the very high standards of care to our patient population. We do, however, want to continue to improve our cancer and elective waiting times, all of which were deeply affected, as were other hospitals around the country, by the COVID pandemic. And as the chairman reflected earlier on in the conversation, we'll continue to stabilise and develop the group executive and operating structure. And I will say a little bit more about that in about 20 minutes time later in this morning's presentation. As with many organisations in the public sector and many NHS organisations, the stewardship of our finances continue to be quite challenging. Healthcare is expensive. Medical innovations continue to come down the line, which is absolutely excellent. But clearly, we are stewards of the public purse, and it's very important that we maintain structures and systems to allow for public taxpayer funded services to be transparent, to be economic, and to be well positioned. And in a few moments, Lee Bond, our Group Finance Officer, will be speaking around some of our financial control systems and how we take those issues forward. As we move forward over the next 12 to 18 months, a lot of our focus is going to be on our digital innovation programme. How we improve IT, how we improve access to medical records, how we harness the energy of information to improve aspects of care and care pathways, both on the South Bank and as we become tighter in our harmonisation with services and specialist services across the North Bank of the Humber. Next slide, please, Sam. So I'm going to pause at that point. I'm going to allow Lee Bond, our Chief Financial Officer, to give some reflections on financial performance. And then towards the end of the next presentation, we will be responding to a number of questions that have been placed in the chat box and published for all to work through. But before we respond to those questions, and we will respond to all of them, I'm going to invite my colleague Lee Bond, the Chief Financial Officer for Northern Lincolnshire and Goole NHS Foundation Trust, to provide some reflections on the 22-23 financial performance. Lee, thank you.
Thank you, Jonathan. Good morning, everybody. I'm going to spend a few moments now just talking through a very high-level review of our financial performance for the financial year ending March 31st, 2023. Just go to the next slide, please, Simon. I will, I believe a little later on the agenda, there is an opportunity for our external auditor to make a presentation. But from my perspective, one of the highlights of the year is the receipt of our internal auditor's report, and it is really pleasing that we've received a true, fair view of our accounts for the year, which is something that we work really hard to provide. So that in itself is an achievement for the organisation. Next slide, please. Not only is the basis of the opinion sound, but we've also been able to demonstrate that our organisation is a going concern, and there are no material uncertainties that would lead anybody to conclude anything other. So on that basis, these accounts have been prepared. Next slide, please. In terms of the actual numbers, the deficit that whilst we reported a deficit on our income and expenditure account for the year, the deficit is adjusted when taken into account as part of sort of whole government accounts, and any technical items such as impairments and grants are removed. And when you take out the impairment that we've suffered from revaluing the estate, you get to a net surplus of £46,000, which was achieved against a planned break-even position. So we pretty much a marginal improvement on our control total, but a very small surplus in the financial year. Next slide, please. In terms of the financial regime for last year, it was a slightly differing year in that we had a block contract remained for all of our non-elective and our emergency activity. So Jonathan talked about the increased activity that we've seen through our emergency pathways, our non-elective pathways. They were still funded on a block payment, but we had the reintroduction of a cost and volume arrangement, what was previously known as payment by results for planned care, and this was part of the government's way, or the NHS's way, of trying to incentivise the recovery of the waiting list. So we had the introduction of the elective recovery fund, which continued to provide funding as and when we delivered the activity for our elective activity. We did have still received some money for COVID, and I'll come on to that in a moment. And we continued the final element of our sort of where we get our money from really was some pass-through funding for very high cost drugs and devices, but that's not huge for NLaG. Next slide, please, Simon. So in terms of where we get our money from, it was a bit of a milestone year for NLaG that we passed the £500 million turnover mark. In terms of where the money came from, the vast majority, as you can see, comes from our local ICB and through the block contracts that we hold. There is a very small amount in there in pale green, for just 900,000, which is the COVID top-up funding. So you can see just how far or how far reduced that has become in terms of a major income stream for us. The vast majority is income for providing services to patients, as you can see through that slide. Next slide, please. In terms of where we spent our money, again, not changing massively. Over 2/3 of it is still spent on staffing, with a further £88 million spent on clinical supplies and services. So they're the variable costs that we incur each and every time we see a patient. Clinical negligence continues to be our single biggest item of non-pay expenditure at just shy of £15 million in the year. But the key standout in here is the fact that 2/3 of our costs are still in the form of staff, and as such we have an essentially fixed cost base in nature. Next slide, please. The value of the trust fixed assets is £279 million at the end of 31st of March 2023. The vast majority of that we own, and within that the vast majority is buildings, as you would expect. Interestingly, only £28 million worth of plant and equipment within there. The vast majority of what we own is tied up in our buildings, and we did, as part of the accounts, undertake a full revaluation, independent revaluation of our estate, as we're required to do. Next slide, please. In terms of our infrastructure in the year, both the chairman and the chief executive have identified the fact that we have invested quite heavily in our services within the year, particularly within our fixed assets. and you can see that was just over £45 million. Within there, the two standout numbers, £18.8 million for the emergency departments and the two AMUs, for which one is open and the other is about to open. And the other sizable increase within there, the top line, was the theatres. We did receive additional funding through what they call the Transformation Fund to upgrade and restore 3 operating theatres. And I notice in the questions, Mr. Riki has asked a question about our elective work. One of our key strands, Ian, is about making sure that we have capacity, both physical in terms of the facilities and human in terms of the workforce required, in order to be able to protect. I think that it was the term you used in your question, to protect our elective waiting list, and to make sure that we're able to manage that and manage the waiting times down. So we're doing that through quite a sizable investment in operating theatre capacity. Next slide, please. In terms of loans and debt, we're not saddled with huge PFI contracts or anything like that. We do have 2 long-term loans, total £8 million. They're not at an unattractive interest rate, as you can see there, and interestingly, we'll pay the first of those off in just over 3 years' time, 5 years for the other. So our balance sheet is not encumbered with significant levels of long-term debt. Next slide, please. I think you've gone past one.
Sorry, Lee, that was the last slide. Yeah.
Was there not one before that about balance sheet strength, Simon? Oh.
No, Lee, that's the last slide.
Okay. Well, just in the interest of completeness, from a balance sheet perspective, our cash and cash equivalents did reduce in the year from 55 to 41 million pounds. As I said, the borrowing's in a reasonable position. What's been really pleasing for me this year is our public sector payment policy compliance has continued to be strong, and we continue to pay 93.4% of our non-NHS suppliers within 30 days, and that's really good for our local economy. So I'm pleased with that. That's all I was going to say this morning. I'm happy to take any questions.
Okay, thank you very much, Lee. I think it probably is appropriate to try and field the questions that we've got in at the moment that are related to what we've heard so far. So just as, by the way, just if you spot Linda Jackson next to me, it's Linda who's joined me in my office, so I'd like to welcome her. So there are some questions around the Humber Acute Services Review. So, and I know, Ivan, you published some answers to that, but can we just go back to those after you've done your slot, please? And can we just get Lee and Jonathan to comment on the questions, please? So they're relevant to what we've heard. So the first one is from Shiv. Shiv Nan's one of our public governors, and I know he's not able to join us today, but the question we've got here that's published is, post-amalgamation of executive boards, I understand that the combined deficit will be 100 million across the entire NLaG Health institution. Is that correct? What does that mean? Does that mean we risk special measures again? And what has been done to mitigate? So, Jonathan, Lee, are you able to comment on that question?
Chairman, thank you. I'll allow Lee, as the Chief Finance Officer, to reflect Shiv's question. Thank you.
Okay, so she was quite correct in the monthly finance reports that I provide to the board. I am declaring circa £100 million of underlying recurrent deficit across the group, and it splits roughly 50-50. So roughly £50 million for NLaG. That figure make some really interesting assumptions around non-recurrent income that we've received this year that we're told is going to be non-recurrent, and therefore we've been prudent and assumed so in that number. But it may prove that some of those non-recurrent sources actually will be made recurrent as part of the planning round for 24-25. So I do think that position will get slightly better. The other issue that one of the bigger assumptions that we make when we provide those numbers is we assume that any benefit that the organisation has received in year from carrying vacancies is assumed to be non-recurrent in nature, in that our aspiration will always be to fill our vacancies at a point in time. Now, you may argue that the accountants are being overly prudent there, because we will never fill all of our vacancies all of the time, and therefore that's an inappropriate assumption to make. But that's within there at this moment in time. So I expect the 50 to go down. It is set in the context of an ICB and a region and a national system where similar sized deficits, particularly in acute trusts, are being reported. So I'm not sitting thinking to myself, either NLaG or Hull are massively out with everywhere else. But in terms of what we're doing about it, I suppose there's 2 or 3 things that we're trying to do about it. One, we're trying to quantify just exactly what the actual number will be when the planning guidance is finally released for next year. But secondly, and this becomes a very dynamic piece, we are continuously trying to identify areas where we can reduce our cost base. And principally, if you think about what I've just said around the staffing being the predominant cost driver, it's around how can we reduce the costs of our staffing. That's not necessarily about reducing headcount, but it may be around making sure that we don't have quite the same level of staff turnover, or that we're able to recruit some of those vacancies that I just mentioned, and therefore able to avoid costly locum or agency expenditure. And that's a strategy that's been promulgated at a national level. We have a lot of work going on. If you think about the second biggest area where we spend money, which was clinical supplies and services, a lot of work going on in that area, trying to identify areas where we can standardise the clinical products that we buy and potentially drive savings there. And the final thing I would say is we're looking at sort of service reconfiguration and service resilience. So Ivan's been leading a really key piece of work around the acute services review. And whilst that's around service resilience and sustainability principally, my full expectation is that by doing that, we'll also build in a degree of financial resilience as well, and that should yield some savings at a point in time. So we are working, and we take all of the national information that's provided through various databases, various benchmarking exercises, in order to constantly try to identify areas where we can become leaner and reduce our costs, and that will get at that underlying position that I talked about. There is a further element to this, and that's productivity. I said that the staffing is effectively a fixed cost. We've got a huge value set in terms of buildings and equipment. So one of the key challenges that the executive team, the board, are working on is making sure that our productivity is maximised as much as it can be, and that plays also to the question that Ian asked about protecting our elective activity. So a combination of improved productivity, which will reduce our unit costs, and actual cost savings, is how I expect us to reduce and manage that £50 million deficit.
Okay, thanks, Lee. So you've mentioned recruitment, retention, procurement, service redesign and productivity as the main themes to attack the financial challenges we've got. So hopefully that will be something that obviously members of the public, governors can keep their eye on as we go through the next year. So thank you for answering that question. I hope Shiv, when he sees the answer, will be satisfied that we are aware of these issues. And the only thing you mentioned was there a risk of special measures coming in on this sort of premise? I'm not aware that we're at risk of that, given the sort of national picture and our position, but has anybody got any comments on that?
I suppose, Mr. Chairman, the reason why I set the context of NLaG within the ICB, within the region and the national position is if somebody said NLaG because of this are going to go into special measures, I think for consistency purposes they'd be putting a lot of hospitals, a lot of organisations into special measures, and at that point I don't think special measures would be the right vehicle for what they're wanting to achieve. So I don't think that will happen.
No. Okay, thank you, Lee. That's great. Thanks very much for answering that. Then, so I'm just scrolling down the questions here. So Shiv's asked some more questions about acute services, and I know Ivan, you can answer that. Ian's question has been answered in writing by Sean Stacey, but I think it might be just helpful if you're online, Sean, just to be able to articulate that answer. So if you're there, you must be.
Thank you, Chair. Yes, I'm here with Simon.
Okay.
Absolutely. I think you've already really touched on it, and so has Jonathan in his presentation. Productivity is the name of the game with regard to this, but as Ian says, how can we maintain the beds that are required for elective? We have, without exception, maintained our elective beds through now nearly 4 years, and we are continuing to do that. It is very, very tight at times, but we know what beds we need. They are planned initially at 6 weeks and then confirmed at 4 and at 2 weeks. And so we ensure as much as we can that we don't lose an elective bed because of the urgent care demand. I think as the SDECs open, the urgent care demand and flow will start to be managed better with the shape of the accommodation that we've got and the facilities in those new units supporting the emergency department and the 2 urgent treatment centres in front of the emergency departments gives us the right facilities to support flow. Demand is always going to be a challenge, and there will be times where demand will exceed the capacity that we've got available. But built into our system for winter this year and in previous years and in future years is a contingency to accommodate what we anticipate the demand is, and improve the emergency department flow. Our problem, as Jonathan has alluded to, is the length of time you wait in the emergency department for a permanent bed to become available. That I really do hope changes with the embedding of the medical model that we started the transformation of in 2018 and will now be concluded and fully embedded with the opening of the new assessment units. I think the other thing to say there that keeps flow going, and we're really pleased and we're grateful to receive this, is the improvement monies that we were given for the discharge lounges at both Scunthorpe and Grimsby, which again allows us to move patients who are ready to go home on the day that they're ready to go home out of their acute bed into a space where they can wait for transport and the other things that are needed to support their discharge, and then go home from the discharge lounge. And we are in the process of extending the running times of the discharge lounge to later in the evening to again help with that flow out of our organisation. That also will help and support our emergency departments, where patients are in the department waiting for transport or waiting for collection by a relative, the department therefore can become quite full, where people are waiting in a cubicle for that to happen. And again, the discharge lounges will begin to support those things. So I think that combination of ring-fenced elective beds, the improvements in our urgent care flow, and the embedding fully of the model will continue to show improvement and signs on our waiting list. There are some other things that I've put in there around maintaining day surgery, increasing the amount of day surgery that we are able to do, maintaining our theatre productivity, and some work around our outpatients, and in particular working with our clinical teams this year on really embedding the reduction in unnecessary and non-evidence-based clinical follow-ups, and the better improved use of first appointments and early access to diagnostics at the front of the journey for the patient, rather than after they've had a single appointment. Those things will help to improve the delivery of waiting list care for outpatients, which is a real priority for us. That's where our growth is. That's where we're needing now to get a tighter grip. And we do need to continue the really good reduction that Jonathan's alluded to in his report on our inpatient treatment services. We still maintain a very good waiting list. Yes, we still have the COVID impact, but our waiting times are much better than others in our area. And so we hope to maintain that this year. And that includes the continued support and levelling up, as Jonathan alluded to, where we are sharing our resources to help others with mutual aid. Sean, I hope that covers that item that Ian has raised, yeah. But I'm happy to answer any other questions on that.
Yeah, thank you very much, Sean. I think you demonstrated, and a great question from you, Ian. Thank you very much for that. That this is like a complex picture that resolves on basically down to the use of, the best use of beds, really, and how we do that at the same time taking care of the patient journey. And making sure we absorb best practice, new ways of working. So it's quite a lot of moving parts there, but it's a great question. I think you've answered it pretty comprehensively, Sean, and Ian, no doubt in other forums you'll say whether we have or not there. So thank you for that. Just scrolling down there, I think you've answered this, Lee, but just and you did mention that on your last comments about being a good sort of corporate citizen. The question was about the timeline for paying trade creditors, and has there been any change over the last 2 years? Lee, you commented that we aim to pay all within 30 days. We're in decent shape as far as that's concerned. I think you did mention a number there, way over 90%. Is that right?
Yep. Yep.
So has that the question? The supplementary was, has that changed in the last 2 years? Not in my.
No, the public sector payment policy is 90%, and we hover around the 90% mark consistently.
Yeah, okay, all right, thank you for that. Next question was about, this is to do with, I can't say who that's from, unfortunately, so I'm sorry, I can't address you by name, but this is about CapEx, I think, and can it be split out to show spend at each site? And there's a suggestion in this question that maybe Grimsby's had more investment than Scunthorpe. It's mentioning that we told Scunthorpe's in bad state of repair. Is this due to more money being spent routinely at Grimsby rather than Scunthorpe or Goole? So have you got any comment on that, Lee? I know you've written something down there. It might be just helpful to articulate it.
So we do very detailed site surveys of all of our. Unfortunately, the capital funding that we have available is pretty limited each year. So the only way in which we can manage is to take a risk-based approach. So we don't at any point go, we're going to favour Grimsby over Scunthorpe or Goole. What we do is we look at the totality of the risks we face, look at the money that we have available, and then we come up with a prioritised sort of investment plan that tries to manage those risks. And it may be that in any one year, one hospital or another does appear to receive the lion's share of that investment, but I can assure you it is done on a risk-based approach each and every year.
Yeah, thank you very much, Lee. And I mean, there is an offer to split that out if the colleague who has framed this question wants to see that. We can certainly do that. Maybe you could do that as a response in the when we publish the answers, Lee, if that'll be helpful.
Yeah, I just haven't got the information to hand, Sean.
No, okay, thank you. But you've explained the premise on which decisions are made, and that's absolutely fair as far as I can see. Right, so Raquel's asked a question which Simon Neary's helpfully answered, which is how much does the trust spend for you on agency staff? Simon, Lee, you've answered a question here, I think. 22 million versus, and that's the same as the period last year. Am I right there?
Pretty much. It's pretty much the same on agency this year versus last year. That, and I'm taking the month 9 numbers, so you can, so it's as up to date as I can get it. But in the 9 months of 22-23, we spent about the same on agency staff. Just on agency staff, there was and Simon Nearney's put a comment about bank and agency costs, which are significantly higher than that. But the sort of point about this, I suppose, is, and it's for all of us to be aware of, and one of the main motivations behind the formation of the group structure is this is a big issue for us to actually attract and retain staff, and the consequence of not being able to do that as well as we'd like to is we do have these huge costs that we contend with. So the more we are able to perform better, the more we are able to show our wares on a national stage, the more attractive it will be for people to come here, live here, work here, and provide great service on top of the great service we already provide. So that is a consequence of where we are, and there's a lot to attract, I think, now, and that attraction will be growing, and we'll have to measure the effectiveness of what we do in that sense. But it's a very big burden on us, and it's one we'd rather not have, for sure. So, right, there's an operational question at the bottom here, just landed in. Again, it's anonymous. This is, Sean, I think this is one for you. It's about when I've been at the hospital, the discharge lounge has been empty, and I've been made to sit with relatives in a ward bed rather than waiting for discharge for hours, rather than being moved to the discharge lounge. So experience says the discharge lounge process does not seem to be used as effectively as it could be in all areas. So any comments on that, Sean, Stacey, please?
Yes, thanks, Chair. I suppose it's really difficult for me to comment on an individual's circumstances, but I'd be happy to discuss with the person that's posted that on an individual basis. Generally speaking, the discharge lounge prior to November wasn't particularly well used. 2 things happened in November. One, the refurbishment of both the discharge lounges was concluded, and then we then ran a hospital and community improvement event across Northern Lincolnshire, which looked at the flow improvement for our patients. And that has been a particular focus around the use of the discharge lounges. We still have a resourcing challenge in our lounges until the recruitment process is closed, but the use of the lounge has increased since that mid-November period by around about 50%. So we're using the lounge for 50% more of the time than was pre-November, and we hope to continue that up until 10 p.m. So I can't specifically answer that question because it's pertinent to an individual, and there are patients who do attend the hospital that are not unfortunately suitable for use in such an environment, particularly those with a chronic dementia or a confused state where constantly moving their environment does not aid their recovery. And so in those circumstances, we probably would leave them where they were till their transport arrived. That being said, that may not always be the case. It's a really difficult question to answer without knowing the circumstances. But I believe from all of the assurance I'm getting and what I'm physically seeing, that the lounges are increasing. They're not to where they need to be, and we know that, and we've got a significant amount of work to do to continue doing on the exit flow from the organisation. But we are working really hard on that. Thanks,
Okay.
Chair.
Yeah, thanks very much, Sean. And just to the questioner, Sean has made an offer to have a one-to-one conversation with you. If you'd like to get in touch with Sean Stacey, who's our Group Chief Operating Officer, Sean, I'm sure we're very happy to understand a bit more detail about your specific involvement with this, and that can only enhance our learning. But as you can hear from Sean, we do need to improve this. The trend is going in the right direction, but you know, each individual is judged on its case is judged on its merits, and sometimes a discharge lounge isn't the appropriate pathway. But it sounds from your question that you probably should have gone where use the discharge lounge. Anyway, Sean, I'm very happy to talk to you a bit more about that. So let me just take a look, going back up there. I think the other questions have been recorded, are probably more appropriately answered when we've talked to Ivan, or Ivan has spoken to us. So let's see if there's a comment here from Caroline. Yes, would agree with that. Better understanding promotion of the use of the discharge lounge. Yeah. Okay, fair comment. So I think we've answered what we need to with at this point, but we'll come back to questions that are not answered. Once we've heard from, Ivan. So the ones that are outstanding are about the public consultation, I think. Aid, make sure I'm right on that, please. Okay, so let's move on then to the annual audit report. Thank you to Jonathan and Lee for your input there and for the questions we've had so far. Brian Clerkin from ASM Chartered Accountants, who's the Trust's external auditors, has got a slot now to talk to us about the annual audit report. So welcome, Brian, and over to you. Thank you.
Thank you, Chairman, and morning, everybody. So yes, Brian Clerkin, your external audit partner and a director at ASM Chartered Accountants. The year ended March 2023 was our first year as your auditors, and I'd like to put on record my thanks to the teams who worked hard to establish good working relationships between ourselves and the Trust. The Auditor's Annual Report has been circulated, and the executive summary within that reflects the outcome of the year. I'm going to just draw out 4 things from that document. The first is, as Lee mentioned earlier, it's a clean audit opinion. So what that means from our perspective is that we are giving an opinion that the financial statements reflect a true and fair view of the results, so the income and expenditure, and the financial position, as in the assets and liabilities at the 31st of March 2023. We're also attesting that the other information included within the annual report is consistent with the financial information, and that the remuneration report, which is included within the annual report, has been properly prepared. And finally, we're attesting that the governance statement complies with the guidance issued by the department. The second thing to draw your attention to in the auditor's annual report is that there were no significant control deficiencies that we needed to draw to management or the board's attention. The third thing is in relation to VFM arrangements. So we have to provide a commentary on the VFM arrangements covering a number of areas. No issues to draw your attention there, but we have referenced the fact that as at the end of March, you were still in the recovery support program, leaving that program in May 2023. So we'll close out that issue in our report to the 31st of March 2024. And the fourth and final thing to draw your attention to in relation to the annual report is that there were no circumstances arising which would have meant we would have had to use any of the other reporting powers available to auditors while conducting our audit. So overall, the audit went well and was delivered in line with the agreed timeframes and fully completed and signed off on the 5th of December 2023. The planning for 3/24 is well progressed. So I don't believe, Chairman, there are any other matters that I need to draw to your attention, but happy to take any questions that might arise.
Thank you very much, Brian. Yes, good to see a clean audit yet again. So well done to Lee and team for the work that's gone into making that something we really can trust. So that's good. I'm not seeing any questions landing in the live Q&A on this matter. So unless anybody else on the screen has got anything to raise, I'll be happy to allow us to move on if that's okay, and we shall then move straight into Council of Governors updates or meeting updates, which is around the development of the group model. Thank you again, Brian, to you and team for some good audit work, and again to Lee and team for providing the information that's allowed us to be able to rely on the numbers that we've got. We might not like them, but at least we can rely on them, and that's good. So well done to everybody for that. So let's move on then to Jonathan, which is item 3.1 on the agenda, and this is the overview of the developments of the NLaG and Hoof group model. So over to you, Jonathan. Thank you.
Yeah, well, thank you very much indeed. So, ladies and gentlemen, over the next coming minutes, I'm going to speak around how we're seeking to harmonise the organisational contribution, both of Northern Lincolnshire Ghoul NHS Foundation Trust and Hull University Teaching Hospitals NHS Trust. And then after I've spoken, Ivan McConnell, our Group Director of Strategy and Partnership, will speak for a short period of time with regards to the Humber Acute Services Review. And then again, the Chairman will happily host questions in about the next 15 minutes or so. So next slide, please. So as we've spoken with Council of Governors and a number of members of the public previously, we are moving to a group operating model that is becoming more commonplace within the English health system. By bringing together a number of care institutions, the NHS is able to create larger, stronger, more stable organisations that have greater opportunity, both in terms of recruitment, retention, greater opportunity in terms of patient experience and the range of services offered to a patient population, and greater opportunity in terms of research and industry investment. And this has been seen up and down the country. So as I said at the beginning of our conversation this morning, I joined the organisation on the 7th of August 2023. And it's at that point, from the gestation in November 22, that we really started to move forward in terms of an identifiable single group structure. So over the autumn period of 2023, we have moved from having two separate executive director teams managing two separate sovereign institutions to having one combined executive team where the executives, Lee Bond as Chief Finance Officer, who you've already met this morning, Sean Stacey as Chief Group Delivery Officer, who you've already met this morning, work and provide support and direction across multiple hospital sites rather than just one institution. We concluded the stabilisation of the executive team just before Christmas 2023. And whilst there's one or two vacancies that we're still at national market with, to all intents and purposes, the executive leadership structure is now fully functioning. Our next phase of restructure and harmonisation is how we draw clinical teams to work more seamlessly together between all of our sites, whether they be on the South Bank or the North Bank. And in doing so, since November 23, running through to February this year, next month, we've been seeking to stabilise appointments to our triumvirate management teams leading our clinical group services. So whether you're a clinician as chief of service, whether you're a care group nurse director, care group operations director, care group therapy director, or care group midwifery director, we've been seeking to bring forward individuals from within the constituent organisations into a new management structure to allow us to enhance the care that we provide both on the South Bank and on the North Bank moving forward for many years to come. To complement that process, we've also been working to harmonise and bring together trust board committees. So as a fully constituted foundation trust, we have a range of trust board committees beyond the trust board itself. So we have audit committees, performance committees, quality committees. And we are currently migrating from single institution committees to committees that speak and challenge and check information, quality and service on a far greater scale, reflecting the size of our group. And I know that a number of governors are already experiencing the differential and progress that trust board committees in common gives us. Next slide, please. So reflecting on some of the key milestones as we've initiated the group transition, starting on the left-hand side of the slide presented, we've had a range of engagement groups for staff across all areas of not only the hospital sites of the organisation, but also our community services. We've brought together a range of very senior leaders from across all of our organisation to start to discuss the common purpose of working together. We've brought senior leaders together as well as staff from across all of our organisation to challenge the values of our organisations with a view to developing a single set of common principles and values, both in terms of care and in terms of standards of behaviour that we can embrace as a group. As we move forward over the next coming months, stabilising the group operating model, and as we move forward with our new senior leadership team, largely taken from internal contribution within the organisation, so individuals who were previously employed either on the South Bank or on the North Bank, we'll be improving our performance and accountability framework. So how we as very executive leaders for health services across this region hold services, hold individuals, hold departments and directorates to account for high quality care. How we release the potential of our greater organisation. But to provide absolute clarity of our direction of travel, by the summer of 2024, and we're hoping for around about July 2024, we will have co-created and then publicly published our 5-year strategy of service. Now, this will be freely available to members of the public, to the Council of Governors and to others, and will lay out in very descriptive format our motivations and desires as to how we will improve service, accessibility and opportunity across all of our region, both on the South Bank and on the North Bank, hospital and community service over the next 5 years. And in so doing, give great clarity and assurance by which the board itself can be held to account. To support that, later this spring, following further consultation, we'll be launching the group branding, the group identifiers, and the values that staff are currently working to co-deliver and co-design. Next slide, please. So you're seeing in front of you now a simple organogram of the very senior leadership, executive leadership of the organisation. And whilst there's a few photos to be added and a few names in place, what I'm hoping this conveys is that we're continuing to move forward well and move forward at pace in stabilising the new group operating model. And over the coming weeks, over the next 4 to 5 weeks, all of the tiles on that organogram that have names in situ, those new names, those new colleagues will be starting in the organisation to bring about an absolute stabilisation of the executive leadership team and our collective contribution to our patients and our staff as we move forward in the coming year. Next slide, Simon, please. So specifically, as this has been a pertinent point of interest with Council of Governors, I'm just going to spend a couple of moments referencing in slightly deeper detail our operating model. So we have taken the decision to harmonise leadership intent between both the North and the South Bank of the Humber. So whilst the two institutions will continue to be sovereign organisations, the way they are managed will be far more seamless and blended between the North and South Bank, and far more harmonised between the North and the South Bank. And whilst myself and the executives cover all aspects of the organisation, the South Bank will still be supported by an on-site, very senior leadership team, as portrayed within this organogram, listing the site managing director, site medical director, and site nursing director for the South team. Those 3 post holders have been appointed to the organisation. One of those post holders is joining us today, sat in the background, but certainly ahead of go live March, April this year, those 3 post holders will be providing the local hospital-based direction of travel, assurance and accountability for the portfolio of services that sit underneath them. So within the organogram in front of you, under the South team tile, it reflects a portfolio of care groups of 7+1. So if we can move on to the next slide, please. So between both the North Hospital team and the South Hospitals team, we have a range of care groups. The slide that's currently been shown reflects the care groups and clinical services that are available throughout our entire hospital region, both on the North and South Bank and our community service, but that are physically coordinated by a management team based at Hull Royal Infirmary. So as you can see from left to right, there are a range of clinical services, cancer network care group, digestive diseases, head and neck, etc. And the pictorial also shows the size of operating budget. So for the North team, 435 million. For the workforce, 6,532 workforce. And for the physical bed complement under their authority of charge, 710. Take the next slide, Simon, please. For our conversation and recognising the specific interest of governors and partners around services coordinated by our South Bank team, the slide in front of you reflects the range of services that the management team that will physically be based in Diana, Princess of Wales Hospital, Grimsby, will coordinate. wherever those services are provided across our greater hospital group. So the triumvirate team and others that we have appointed will coordinate all of family services, as an example. Both the 2 midwifery departments on our South Bank at Grimsby and at Scunthorpe, our community midwifery service in Goole, and also our midwifery services in Hull and the East Ridings district. In so doing, coordinating our efforts and energies clinically to a wider population within specialist firms. And you can see across the totality of this slide that our South Bank Managing Director team is no less influential or important to us than our North Bank team. You can see that their operating budget responsibility, £448 million, is very similar to that of their northern colleagues. Their coordination of workforce of 6,510, similarly so, no less significant. And actually, in real terms, they will be charged with services, providing services from a greater bed population, 1,372, than their North Bank colleagues. So as we start to move forward at pace, as we move forward into the 24-25 operating year, members of the public, Council of Governors on this call and others should be assured that the ownership of clinical services that we provide is clear, is structured and is coordinated. That the physical management that we introduce and maintain to our hospital and community services on the South Bank is similarly robust to previous, is accessible, and brings about a very real and meaningful leadership contribution on behalf of our patients and the community that we serve at large. Next slide, please. So I'm going to pause at that point. I'm going to invite my colleague, Ivan McConnell, our Group Director of Strategy and Partnerships, to speak for about the next 10 to 15 minutes on the progress that we have made on the Humber Acute Services Programme review. At that point, after Ivan's spoken, the Chairman will happily field questions, both from the chat box or others, to myself, to Ivan and to other colleagues of the Group Executive. So Ivan, thank you very much.
Thank you. Thank you, Jonathan, and good morning, everybody. I'm going to do a little bit of a double act this morning. So, as Jonathan said, I'm Ivan Connolly, Group Chief Strategy and Partnerships Officer, and I have had the privilege of leading this programme on behalf of the ICB. I have with me also Dr. Lindsay Cunningham, who has led on behalf of the ICB the consultation and engagement process, and I thought it was important that she was able to articulate the work that's been done, and I will talk about where we might be going. We've tried as we've gone through to answer some of the questions in the chat, but as Jonathan has highlighted, we'll pick those up as we go. So in summary, the Humber Acute Services Programme is at a critical stage. We have just completed the consultation at the beginning of January, and that consultation is currently undergoing significant analysis by an independent body. When we receive that, we will then feed that into a process that we have that looks at how we consider what that feedback is and what the implications may be upon any recommendations that are made. I think important for colleagues to remember, this is not a NLaG programme, this is an integrated care board programme, and it is the integrated care board that make the decision on how we move forward. But really important to recognise that we have been given the privilege as we have gone through this exercise of leading it, and I think we should applaud our ICB colleagues for that, but equally recognise the hard work of all of our operational and clinical teams that have fed into the work that has brought us to where we are. In terms of the next steps, we're anticipating completing a decision-making business case, which will summarise what we are proposing to do to go to the ICB board in either May or September. The expectation is that we will do it by May. Those two dates are fundamentally driven by the election cycle this year. So we have 1 week in May and 2 weeks in September, assuming local authority elections, devolution elections and a potential general election at the back end of the year. So that gives us 2 windows. As we go through the process, we will be looking at, and it reflects some of the comments in the questions, transport, which has come up, but recognising we are not a statutory transport provider, so we need to look at those options. We will be looking at equalities and inequalities in more depth, and we are looking, as Lee has highlighted, about the finance and also the workforce. So the next slide, please, Simon. So Dr. Cunningham's going to walk you through what we've done from a consultation, and I'll walk you through a summary of the key issues. Lindsay.
Thank you, Ivan. I think Ivan's covered a number of the points on this slide, but really just in terms of updating where we are in the process. What I'm going to do is talk you through very briefly what it was that went out to consultation and the process of consultation and what that entailed. And then Ivan will finish off the presentation with a little bit more about what we're doing next. So we received a fantastic response to the consultation, which closed on the 5th of January with nearly 4,000 consultation questionnaire responses, as well as a large programme of events and engagement. And really interesting to hear lots of the themes and ideas and issues coming out through that consultation. And we'll touch on them in a moment later in the presentation. As Ivan said, there's a long process now at this point to really carefully consider all of that feedback, and that does take some time because it's really important that we don't rush that part of the process. It's really important that we take the time to understand each of the bits of feedback, what it is that people are concerned about, and really how we could potentially respond to those issues and concerns. So if you move to the next slide, please, Simon, I'll just cover very briefly for the benefit of people on the call. You may already be aware, but just to take you through very briefly, what went out to consultation as a set of proposals was around bringing together a very small number of much more complex specialist elements of care that are currently provided at both Grimsby, so it's Diana Princess of Wales Hospital in Grimsby and Scunthorpe General Hospital. The vast majority of services would continue to be provided on both sites, and the vast majority of patients would continue to get their care at their local hospital. I won't go through every point on this slide, but just to reiterate that 24/7 emergency departments in the fantastic new facilities that we've got, that Jonathan's mentioned already earlier on the call, would continue on both sites and wouldn't be impacted by the proposed changes. And similarly, the vast majority of those other services that support, so your acute assessment unit, same-day emergency care, critical care and anaesthetics, and all the other support services would remain on both sites. Similarly, nothing in the proposals around obstetric-led units or maternity care, planned surgery, outpatient services would continue as is. So that's the vast majority of patients coming through our hospitals would continue to go to the same places. If you move to the next slide, please, Simon. The 4 service areas that were in the proposal to be brought together are a trauma unit, which is for people who have injuries that need specialist care. Typically, those patients are brought by ambulance, but needs that higher level of care by a specialist trauma team. A range of acute emergency surgery, so we do very few operations overnight, around 1 per night across the 2 hospitals, across Grimsby and Scunthorpe. The proposal was to bring those surgical services together in 1 hospital to reduce the number of on-call rotas that we would need to provide and to improve the quality of those services. The third area is around some of our medical specialties, and particularly looking at, for example, cardiology, so looking after patients with heart problems. It's a small element of that service would be brought together in a specialist cardiology ward on the Grimsby site for patients who either need much more specialist care or who need to be in hospital for longer than 3 days. That doesn't mean that everybody with a heart problem would have to go to Grimsby, but it's for those patients who require that specialist care. Bringing them together in that way would enable services to be provided 7 days a week with consultant-led cover, enabling us to reach certain clinical standards that are not currently being met across the hospitals. And the final area proposed through consultation was around consolidating paediatric services for inpatient care. Again, the vast majority of patients who come through the hospital, children, young people, would continue to be seen and treated through the emergency department, paediatric assessment unit. But for those smaller number who needs a longer stay in hospital, the proposal is to bring that service together to a single site. So as I've said, that's in a nutshell, very briefly and very quickly, what went out to consultation. We are still considering the feedback, and that may or may not be what comes through for decision at the end of the process. If you can flip to the next slide, please, Simon. So what did the consultation entail? I won't cover all the detail on these slides, but just to give you a bit of a flavour, there was 3 core strands of the work. A large amount of effort went into promoting the consultation, whether that was through television, local radio and news media. And we also put a significant amount of money into paid for social media advertising to ensure that people heard about the consultation. And we did get a lot of interest from local media and a lot of support from particularly from Trust colleagues in terms of responding to those requests to go to media interviews, etc. And that really helped to generate a lot of public discussion about the consultation. And the next slide, please. We held a number of events, including large-scale exhibition events with significant numbers of colleagues from the ICB, from both from the group, from across the group, clinical teams, as well as managerial leads. And people really found it beneficial to come to those events and to have long and in-depth conversations about what the proposals might mean, how they've been brought together, and really have an opportunity to talk about some of the concerns that they've got and some of the things that the benefits that they could see with what was being proposed. And on the next slide, please, Simon. I think probably the most, at least one of the most important parts of our consultation process was the work that we did around our targeted engagement. And that was about taking the time to identify any particular groups or communities who might be more impacted by any changes that we'll be looking to make, and going out of our way to have conversations, to listen to those groups and to really understand at a much deeper level what the types of issues and concerns that they might have. We did this through focus groups with particular cohorts of population. We also used a specialist drama-based company who specialise in working with harder to reach or people who generally don't get their voices heard in these kinds of exercises. And that was really important, and actually a lot of the intelligence and the insight that we gathered through the consultation, not necessarily about the proposals, but often about other aspects of healthcare that people find challenging. And a lot of those things, some of them that group and trust colleagues can pick up, some the ICB colleagues, some to do with much wider issues of health and care, but really important that we actually can use that insight and intelligence to change what we do and how we do things. So that was probably one of the most important parts and elements of the consultation. And go to the next slide, please, Simon. This is the last one. I'd be glad. I won't again cover all of this, but really important just to highlight throughout the consultation, we monitored where we were getting responses from. So we looked at the postcodes of people who were responding, as well as lots of different demographic information. And we were measuring that in real time, which allowed us to put on additional events or additional workshops, additional means of reaching to specific communities and groups that weren't engaging as much as we would have liked. So there was a handful of specific groups that we identified and then put in place additional actions to make sure that we heard from them. So we're confident that we have got a really good and really rich set of feedback. I'm going to hand over to Ivan now, who's going to tell you the important bits.
Thank you. So thank you, Lindsay, and I'm sure colleagues on the call, you would all applaud the work that has been undertaken in terms of the range, the scale and the depth. The next slide, please, Simon. That work has been reviewed, just for everyone's benefit, by the Consultation Institute independently, and at the moment we're sitting within a gold standard, which is the highest level of accreditation of engagement exercise, and I think we should applaud that work. I think important to recognise we've not concluded our deliberations. We are partway through analysing what we get, but we have had some interim findings from the independent body undertaking that process. So what have they told us? They've said there is a clear recognition of individuals who have responded across the piece, both qualitatively and quantitatively, that we need to make some changes. There is great support for the principle of continuing to deliver emergency services and most outpatient services as set out. And actually the impact of this programme at this moment in time is probably at a maximum of 7 patients a day. So if you just reflect back to some of Jonathan's earlier numbers, it is a very, very small percentage. Additionally, we had some things around potential quality of care and access. Some people were concerned about services moving from Scunthorpe to Grimsby. I think important to recognise that we actually currently only provide some services in Scunthorpe, not in Grimsby, notably stroke and urology. And those actually have received really positive feedback in terms of the quality and access. So I think important we reflect on what we know from what we've got against what we've done. People have raised issues about ambulance services. I think that was in the chat, Chairman, so I'll answer it now. We have worked with ambulance colleagues. We have mapped every ambulance journey by postcode, by condition to nearest accident and emergency department. That has highlighted that assuming no improvement or efficiency within the ambulance service, it requires half a dual crewed vehicle to service the needs of the changes. Our ambulance colleagues are very happy that with efficiency, they can certainly meet that level of demand. And clearly articulated that at the North Lincolnshire Health and Wellbeing Board recently. I think the big thing that has come up, 2 big things have come up. One is around paediatrics, and that's work in progress and consideration. And the other is about access and transport. So we are looking at a few things. So the next slide, please, Simon, just in terms of those. And I'm going to maybe just give you a couple of points on those. Thanks, Simon. So when we're actually looking at it, we're currently having a look at some of the demand and capacity analysis. As I say, we've done the ambulance transport analysis, again done independently and verified by NHS England. Currently looking at a transport action plan, and within that there are a number of things we just need to consider, and I think things that actually impact on all patients, not just those impacted by the review. One is around the fact that the Integrated Care Board reimbursement process is timely, time-consuming and not easy to follow. So we're having a look at what that process might be. Additionally, we're looking at clinic scheduling and what the implications of that are, because currently there are issues for individuals from different bits of the geography being sent for outpatient appointments in particular across the geography. So we're going to have a little bit of a look at that. And then inter-site transfers, whether that be blue light vehicles or indeed patient transport vehicles or voluntary sector, we're working through that with a working group. I think important to recognise that there were a number of issues, particularly for North Lincolnshire citizens, in terms of the feedback about public transport, and really important to recognise that we do not commission public transport. That is commissioned by the local authority, so we will be making recommendations in the decision-making business case for the local authority to consider and link that potentially to the devolution funding deal should that move forward. So the next slide, please, Simon, just gives you a summary of the timeline and the process. We're currently going through the analysis. We do need to update the integrated impact assessment because clearly it's really important we understand the impact on everybody and we understand that by geography, by condition, and we're in the process of redoing that exercise. We will produce the decision-making business case for April, and then all things being equal, we will go to the Integrated Care Board on the 8th of May. That will then lead to a Joint Health Overview and Scrutiny Committee review, which I think has been alluded to in one of the questions. That Joint Health Overview and Scrutiny Committee, under the new terms of the NHS Act 2022, following enactment at the end of January this year can refer to the Secretary of State on two issues. One is the engagement process, which they have acknowledged is a very good one, and the other, which they have raised as a potential issue, is about the potential impact on local people. That would be a referral to the Secretary of State. That can take up to 6 months to clear. However, the threshold and the bar for that referral is significantly high. So we would hope that we would not get a referral, but I think important, given it was raised in the question, that we reflect the fact that there is a potential duty of that group, should they see fit, to make that referral. So thank you, Chairman. Hopefully that has answered some of the additional bits raised in the questions, but more than happy to take any questions as required.
Thank you very much, Ivan and Lindsay. That's been a great presentation. And firstly, can I just say a massive thank you to you and your team and all the clinicians and other staff involved in the consultation. I do recognise it's been a heavy burden to do this job well, but I'm really thankful to you for having put the work in and created the conditions for a comprehensive consultation. And the engagement we've had from staff and clinicians has really been outstanding. So I'm grateful to Kate and your team for putting attention into this. So can I just make sure we just answer these questions specifically? I'm just going back to Shiv's question about what might happen to, for example, you talked about a pregnant woman who goes into labour at 6 p.m. What happens there then? He's just asked for a walkthrough on that type of scenario, given the proposals for consolidation.
Yeah, hopefully the response to the question was quite comprehensive, Chair. But in terms of the 2 points raised, one was around a fractured neck of femur. If my memory serves me right, at 6 o'clock in the evening. We would follow the clinical protocols and guidelines for that fractured neck of femur, which is the patient should be operated in within 36 hours. Currently, in following that process, the patient would be assessed, triaged, and more than likely operated on the following day. So I think important that we recognise that's building on current guidance, clinical guidance, and actually follows the process we follow at this point in time. As Lindsay outlined earlier, there are no changes proposed to obstetrics, so there would still be 24/7 obstetric cover.
Fine. Okay, so this is really making sure that the full understanding of these scenarios is actually really clear to people who might not quite get the impact of the proposals clear in their minds. But this is all about communication, and I'm grateful for the work that's been done. Where we are now then, Ivan, is in the review stage of the feedback. One of our questioners has talked about the joint councils. I think it would be fair to say potentially making this a referral elsewhere. That remains to be seen, doesn't it? We can only at the moment go through the commentary, the review. You will make your recommendations to the ICB, and that will be taken from there on. But of course, our council colleagues do have the rights of, as you've mentioned, of referral, but they will have to meet a bar that's established. So this has all been done in good faith, the intention of providing better care, more consistently, safer. There is an impact, of course, and most people are worried about transport, and the answers around that are not completely worked through, but all the concerns have been raised. So I don't think we can say any more today about that, other than to congratulate everybody on a massive piece of work and the quality of the consultation, which has been reviewed the Consultation Institute, as you mentioned, nobody's saying anything other than it's been a gold standard piece of work. So thank you for that. No doubt we'll come back to this in due course, and it's important that we listen very carefully, even though the consultation is closed, to any anxiety that comes out from members of the public or staff on this. So thank you very much for that. Can I just go back to the question list here? I think, Lee, you've added to a question that was talked about earlier on regarding CapEx and the distribution of it between the sites. Do you just want to amplify that, please?
Yeah, we've just had a look at the 3-year capital programme, and in terms of splits between the sites, the capital programme splits slightly favours Scunthorpe over the next 3 years. But that is subject to change because it depends on the resilience of the estate as we move through that 3-year period. Yeah.
Okay. No, that's the intention anyway, Lee. So thanks for that. So 53% into Scunthorpe, 31% into Grimsby, and 11% in Goole. So. Okay, so that's the intentions at the moment. Now I'm just making sure that we've covered all the questions. I think we have actually. Just be my conscience on this, please. Make sure we don't miss anything. I think we have, sure. We've covered everything. Thank you very much. Right, so that gets to the end of the presentation sections. We're now into just an open opportunity for members of the public or anybody else, for that matter, to ask any more questions through the virtual format that we've got. I'm not seeing anything come through, but I'll just leave it for another few seconds. If there's nothing else, then I'd be very happy to hear feedback from people either now or elsewhere around whether this format has worked for people. It's the first time we've done it on a Teams live event, and the intention is obviously to make sure that events like this can reach as many people as possible. We've had about 21 attendees during the course of today. I'd like that to be much more than going forward, so that members of the public can really get engaged, but more work to do on that, I think. But I'll be very happy to hear from anybody either now or later about how this has worked. So if there's any comments, I'll hear them now. If not, we can ask the questions outside. Unless there's any other urgent business, then, colleagues, I'll think I'm in a position to be able to draw this meeting to a close with a reminder that the next Council of Governors business meeting, which is a meeting held in public, will be on Thursday, the 18th of April at Scunthorpe at 9:30 AM. So we look forward to seeing governors and board members at that. And unless there's anything else, colleagues, I'll commend the annual report to everybody. It will be published on the website. The questions and their answers will be published on the website as well. And I'd like to thank you all very much for the presentations of the work you put in so far. Simon and the team for guiding us through the technology. And unless there's anything else anybody wants to raise, I'll draw this meeting to a close, and I hope you have a great rest of the day. Thank you all very much, and we'll see you soon.
Thank you. Goodbye, everybody. Thank you.
Bye. Thanks all.